This is The Healthy Healer, where true voice is your medicine. This is where we help doctors and other healers navigate through the challenging times by learning from the best minds in the healing industry. Laugh, cry, and be surprised. It's entertainment, education, and inspiration so you can continue to be the unique and amazing healer you were destined to be. Welcome to humanity. Welcome to The Healthy Healer with Dr. Fred.
Hello, everybody. It's Dr. Fred, and welcome to our next amazing episode of The Healthy Healer. And today we have another physician, and I'm really excited about that. An actual physician, an MD, not just somebody who's an MD doing conventional work, but an MD who's out there actually healing people with chronic conditions, and doing so from a kind of a perch, a peak, a top of the mountain, but top-down approach. It's a man who has found himself as the president of the Psychophysiological Disorders Association, ending the chronic pain epidemic. This is a lofty goal for sure, but from what I understand about David Clarke is that he's up for the task, and he and his colleagues have put him there for a reason. As the president, this is a man who has really studied this for many years and has a take on what it is that chronic pain is caused by and how to make a difference in that using the whole holistic human being, not just the body, not just the mind, but the whole human being, body, mind, spirit, emotion, etc. So without further ado, here's David Clarke. David, thanks for being on the Healthy Healer today. It's great to have you as a guest.
Great to be with you, Fred, and happy to be able to share the ideas with you today.
Fantastic. David, if you've heard any of my podcasts before, I have a simple 9-letter question that I like to ask my guests to get launched. And it is really just fantastic to have you here. And this question is grammatically correct and often really just opens up the gates to the conversation, the organic conversation that we're about to have. So here it is. David Clarke, who are you?
I'm a gastroenterologist, for one thing, but more than that, I'm somebody who can work with patients who have pain or illness, but not a disease or injury. In fact, I've interviewed over 7,000 people in that category where the diagnostic tests are not showing any explanation for why the person is in chronic pain or has an illness. And I got started with this in the early 1980s. And I was sailing along in my medical training at that point. Everything was going great until I slammed into a patient I didn't know the first thing about diagnosing or treating. She had been sent to us by another university, and we did some very specialized testing where I was in training at UCLA. And that testing was also normal, which shocked my department chair. And I was doing this woman's exit interview and basically telling her she was going to have to live with her condition when I stumbled on the fact that she had been abused as a girl. And I had never encountered that in a patient before. I didn't know what to do with it, but I fell back on basic training and just took a history. And sadly, it turned out that she had been molested not just once or twice, which would have been bad enough, but hundreds of times. But that nobody had touched her against her will for 25 years. So I couldn't see that it was connected to her illness. She was now 37 years old. But I knew of a psychiatrist at UCLA that had an interest in these mind to body conditions. I referred the patient to the psychiatrist, never thinking for a moment that anything would come of it, and forgot all about the patient until a few months later, I ran into Harriet Kaplan, the psychiatrist, in an elevator. Just to make conversation, said, "What's going on with that patient?" And it turned out that Harriet had cured the patient with about 10 sessions of counseling. Absolutely upended my world that you could alleviate a serious physical condition just by talking to somebody. But I had her teach me her framework for thinking about these things. I built on that in my own practice because I quickly found it was 1 out of 3 of my patients that had these conditions, not necessarily as severely as that first one, but still having that mind to body connection to their symptoms. And I gradually got better and better at being able to heal people with that. But it was completely outside of my medical training. And I'm sure it was for you as well. And even coming from the psychiatric side,
For sure.
you probably weren't engaging with people who were in chronic pain or had other physical illnesses. But the great news about this is that it's 40% of people who come to see the doctor, and they can now be treated. There are randomized controlled trials that show this is an incredibly successful technique. It's some of the best news in healthcare of this decade.
My goodness, this is amazing and very beautiful work. And I thank you so much for being you and for discovering Dr. Kaplan and for realizing and even having that conversation in the elevator about this client, this fascinoma that you had, where you had done essentially a full scale run of testing and
everything.
Everything that could possibly be imagined and only imagined, and then only found that the pain wasn't connected. The pain, the experience of being in chronic pain wasn't connected to an identifiable source of a disease or injury. Yet, when you look back to the history, you found out that she had been chronically abused as a child and that there was a direct connection that Dr. Kaplan was able to identify. One of the things I noticed that maybe you don't notice, or probably that you do in your speech, is you use words that most of us conventionally trained physicians aren't even taught to use. And you use them openly, honestly, and regularly, and that's words called healing and cure. Now, both of those words are not words that we necessarily learned in medical school and in our conventional training. Containing, managing, dealing with, treating. You did use the word treating a couple of times too. But it's not just treatment that you're after, is it? It's actually the alleviation of the condition and a return, if you will, to a life without the condition altogether, like a life of being healed through powerful conversation. And it sounds like maybe other interventions as well. But in what you do, it sounds like powerful conversations and harmonic resonance of the human connection is a resource that you utilize to help people actually heal and cure the condition that they came to you with, not just deal with or medicate or hide or veil or cover over, but actually get to the roots of it and remove it entirely so that health and cure becomes a possibility. Am I in line here, Dr. Clarke?
Yeah, absolutely. You and I both know, and it's still true to this day, that what we're taught about these patients who have no disease or injury to explain their symptoms is that they're neurotic. It's all in their heads. The symptoms are imaginary. You can't diagnose them. They're just going to have to live with it. They're really outside what the healthcare system
we have derogatory
provide.
terms that we would use in the trenches.
I'm not even going to go there.
Exactly.
Yes, you're absolutely right. Yeah, it's terrible, dismissive, disrespectful. When in fact, these patients are, I think of them like Olympic champion weightlifters who've been given more than the Olympic record weight for their class to carry. They're very strong people, these patients. They're just being asked to carry enormous burdens of stress that would bring any of us to our knees. But the problem is they don't recognize the magnitude of the stress that they're under. That patient with the hundreds of sexual abuse instances between the ages of 4 and 12, she was telling me this in the same tone of voice you'd use to read a grocery list, that there was no reason to believe that she hadn't fully processed this and moved on. But instead, what was happening was that all the emotions around that were severely repressed. They were not subject to her conscious recognition, and they were manifesting themselves physically. And this is what I found over and over again. Very high levels of stress that can be coming from a variety of different areas of life that the patient is not recognizing. And if I can help them to see that, if I can help them to see the connection, then we can bring it out into the open, we can talk about it, we can alleviate it, and the physical symptoms go down in parallel with that.
Fantastic. Really great, Dr. Clarke. Thank you for doing your job. It's fantastic who you become. And it's been a course, I imagine. I see here that your degree is from the University of Connecticut. And so you have a classical training entirely. And then some of the conditions that you list in your bio or in your one pager that came with you are conditions that otherwise often get called psychosomatic, right? We put that term together. And my understanding is that's not far from the truth, actually, if you take apart that term. That's something you can apply there without having it be a misnomer. There is something about the interconnection between the psychology and the somatic experience that you're capitalizing on, that you're exploiting, that you're taking advantage of, or that maybe not taking advantage, I don't really mean to say that, but you're actually understanding and getting underneath the whole human so that you can address this experience of the Olympic weightlifter carrying around weight that far exceeds even anything in the weight class has ever experienced.
Yeah, psychosomatic is technically a correct term, but it's acquired so many connotations
It has
that
indeed.
you get labeled with that as a patient, and you're being dismissed
Hypo,
by everybody.
malingering, and all those things start getting thrown in.
My colleagues and I, we like psychophysiologic, a combination of psychology and physiology, because that means that it's everybody's responsibility. If you're a primarily mental health oriented clinician or primarily a biomedical oriented clinician, we need to collaborate with each other if we're going to get the best outcomes with these patients. And when we do, the outcomes can be extraordinary. One story I love to tell is about a patient who was hospitalized at a major West Coast university, not too far from where you are, and 60 times in 15 years for attacks of extreme dizziness and vomiting. And she saw everybody that could possibly be relevant in that institution, including a psychiatrist.
Of course.
And they all missed it.
Yeah.
And it turned out that all of her attacks could be readily connected to interactions with her emotionally and verbally abusive mother. And as soon as she saw those connections, it was like the sun breaking through the clouds. She saw it immediately. And in her case, she was cured on the spot.
That is fantastic.
She never had another episode.
Cured on the spot. Amazing. And this is what you're talking about. You're talking about these things that you call ACE, the adverse childhood experiences. And the direct connection between experiencing these things may be as significant, overwhelming trauma, and then not metabolizing them effectively. Metabolism is often thought to be a physiological experience, but it's more than that, isn't it? It's a psychophysiological experience. It's something that really that you get the event, and not everybody responds to the event with the same level of traumatic residual. But many people do, and especially when you're carrying a lot of, like you said, the analogy of a weight greater than any Olympian in that weight class has ever seen, there is an opportunity to get a breakage, or we should say, at least in psychiatry, as I recall, there was one thing called a somatic equivalent. That's what we would call it, a somatic equivalent, that depression as a somatic equivalent, or anxiety as a somatic equivalent, or like a breakdown as a function of a somatic equivalent.
Yeah.
So what is it about these childhood experience, adverse child experiences? What kind of person is it? Is there something that leaves somebody more predisposed to having conditions that then lead to chronic pain or discomfort that otherwise will leave the general conventional physician confused as to its cause?
I think there's a lot of factors that come into play, but when it comes to the adverse childhood experiences, clearly we can't go back and change those. Those have happened in the past, and I've seen a lot of clinicians who have the attitude that, I'm sorry if the person went through the ACEs, but that horse has left the barn, and there's really nothing we can do therapeutically for such a person. As a psychiatrist, that's not true. In my world, there are three major long-term impacts in which we can absolutely intervene beneficially. The first area is in personality traits that many of these patients have acquired as children as part of their survival process, but they then carry them on into the adult years where they are very stressful. Low self-esteem, for example, poor self-care skills, perfectionism, excessive self-criticism, poor assertiveness, a tendency to choose narcissists for long-term partners, for example. All of those things and many more are highly stressful, but can also be successfully dealt with, successfully intervened with in a way that can change the personality traits, especially when the patient sees where they came from. The second one is the triggers, something in the present day life that is in a way linked to the past, that has a heightened emotional response associated with it because of that link to the past. The single most common of those is having an abusive parent still be in your life today. And my patients very surprisingly frequently do not realize the impact that person is still having in their life. The patient who was hospitalized at a major university with the vomiting 60 times, that was the case for her. That mother who was abusive was still in her life at the age of 50. And then the third major long-term impact of the ACEs are repressed emotions, usually anger, sometimes fear, can be shame, grief, or guilt as well, that the patient simply is not consciously aware of. And those emotions need to go somewhere. So they get manifested physically instead of verbally.
That is amazing. It makes a lot of sense. The shutdown that often happens, I assume in the polyvagal world is, I'd love to learn a little bit more about what your interface is with the polyvagal world. And is there something there that's worth taking home? How can we address this? I guess I'm not really saying prophylactically, but there must be some home care that we can offer that doesn't have someone have to come through the eye of the needle to see Dr. Clarke in the office in order to get some level of repair in place, some level of hope or faith or possible even release of the pain that they're experiencing by practicing some methodology or learning about some different points of view or mindsets that might be available. What do you have to say about that?
Yeah, the treatment process is actually pretty straightforward. It starts with the idea that if you've been to the doctor and they have been looking for a bodily explanation, a disease or an injury to explain your symptoms, and they're not finding it, then by far the most likely explanation is that your brain circuits have changed. And we've got fMRI studies now that show that the neuroanatomy in these conditions is actually physically different. Why is it different? It's because of this stress, this high level of stress that is not fully recognized by the patient, which might be in your life today. It might be a long-term impact of the ACEs, or it might be a garden variety mental health diagnosis like depression, anxiety, or PTSD that simply hasn't been recognized as such. Once we've got the patient thinking about their brain and what might be impacting it, they can start thinking about, all right, where are the stresses in my life right now? How can I uncover those, recognize their magnitude more accurately? One of my patients, he only got his symptoms while he was driving to work. When he was driving home from work, he was fine.
Wow.
And as soon as we started thinking about that, it became very obvious that his stress level at work was through the roof and that it corresponded chronologically with the duration of his illness. Other people, it's more complicated to sort that out, to figure out where the stress is coming from. And still others, we've got to dig even deeper and help them bring the repressed emotions into conscious awareness. But there's a process for that. The website endchronicpain.org, that's endchronicpain.org, has a really carefully designed 12-item self-assessment quiz. Then we've got references to books, conferences. We've had 2 national conferences in the last couple of years, courses that are available, podcasts that are coming out, lots of different resources that I didn't have available to me when I started in practice to help people work their way through this process. And many of them can do it themselves. There are people who have just read a book or 2 on this topic and noticed dramatic improvement just from the insights they get on the printed page.
Fantastic. I really love that. I want to ask you a question, maybe just a theoretical question, or yeah, I think it's theoretical. I think that's a proper term here. The idea is that in providing your clients, your patients, your customers with the information through a powerful conversation, what actually takes place? In other words, what is your understanding of, like, once I understand that my pain is caused by my relationship with one of my ACEs or a lingering, deteriorated relationship with a family member or something like this, or something that is a trigger, something that is a reminder of those experiences in such a way that it slams me into being dysfunctional or imbalanced. What is it that happens when I'm aware that you're aware of what's at the bottom of all this? What happens to me that snaps me back, if you dare, into being healed or cured? Are we looking at the Freudian notion that we get cathartic to the point of addressing where the toxin was or where the negative impact was, and once it's addressed, it's eliminated? Or what really happens at that flashpoint?
Yeah, it varies obviously depending on the individual and the particular stress or stresses that are most dominant in causing their illness. But The most common in the people who find their way to my office, and this has been true for 40 years, is that long-term impact of the ACEs. And it's very common when people first come to my office to hear from them that the childhood experience I had wasn't really that bad. And other people seem to have been through worse than me and they seem to be fine. Or I think I've dealt with all of that now. I really think I've moved on from those past traumas and I'm ready to think about something else. And I hear that very commonly until I ask them to do what I call the butterfly on the wall thought experiment, which is to imagine, for the patient to imagine themselves a butterfly on the wall of their childhood home. And while they're there, they are watching their own child or a child that they care about trying to cope with that same childhood environment that the patient was living in. And that gives them a completely different perspective. They're no longer looking back at their own life. They're imagining somebody they care about, especially their own kid, trying to deal with all of the same stuff that the patient did. And you see the facial expressions change when you suggest this. And sometimes they will just say, "Oh my God, I wouldn't want my kid in that environment for 5 minutes." And they suddenly get a completely different perspective. The emotions around what they went through that have been buried sometimes for decades suddenly become a lot easier to access. And that's often the first step toward a realistic understanding of what they had to overcome. And that can then lead to all of these different long-term impacts begin to change.
Yeah, I love the idea of it's like a hovering observer of my own experience rather than whatever that I'm experiencing so-called subjectively, which doesn't really give me a perspective of what I really went through. It's only coming through the meat grinder is totally different than actually seeing the meat grinder I came through. And there's a whole different experience there. The other thing is, it sounds like it's an interface with things like constellations, or maybe more so internal family systems, like really taking a peek at ourselves from different perspectives and getting the multidimensional nature of how we as humans are traumatized and our homeostatic vital force, which has a deep interest in bringing us back to the healed state. I think you're just taking advantage of that, and I really appreciate that a great deal.
Yeah, I think you're absolutely right about that. And it accounts for why the transformations can be so quick. Many of my patients, of course, need years of psychotherapy to achieve their ultimate good outcome. But I've seen many patients, who've been ill for years. One of them, 55 years of documented abdominal pains. And volume 3 of his paper chart was 3 inches thick. And he was cured in about 30 days. Just by uncovering the connection to the fact that he'd been severely physically abused as a boy. I got him together with basically a class/support group led by a therapist. And in the course of that class, he just unburdened himself. He had a tremendous cathartic experience in the 3rd week of the classes, and his pain just melted away after that.
Amazing. So promising. Thank you so much for being who you are. I really appreciate all your work. And I imagine that anyone who's listening or watching this program is going to appreciate your work as well. So I'm asking you, if people want to follow you or read about you or maybe read things that you've written or read about your organization, what are some of your suggestions on the best way to get a hold of you?
Yeah, most of my work since 2011 has been with endchronicpain.org. It's the Psychophysiologic Disorders Association website, and we are constantly putting new material on there that's designed to help patients cure themselves. And we do conferences and textbooks, and there are documentary films and all kinds of resources there, including a new course that's going to be released next week that covers a lot of the issues we've spoken about today.
That's fantastic. That's great. And if you had one thing to tell the general public about this whole idea of chronic pain, otherwise undiagnosed, or anything at all, any kind of gem or nugget that you'd like to leave with our listeners, what might that be, Doctor?
I would just say that when you have pain or illness that is not explained by disease or injury, then by far the most likely explanation is that the pain or illness is being generated by the brain. Many people have heard of phantom limb pain, where someone who's had an amputation and they're feeling pain in the location where the limb used to be. That's brain generated pain. But this can happen to anybody if they're under enough stress for a long enough period of time. And there's a tremendous amount of hope in that concept because this is a diagnosable and treatable condition.
Fantastic. And not only diagnosable and treatable, but really curable and healable, right? We're really looking at the back end.
I've
really
seen it thousands of times in 40 years.
Fantastic. Dr. Clarke, you're a massive inspiration. Thank you so much. What a great conversation. Thanks for being with us today on The Healthy Healer. It's been a pleasure having you as a guest.
Thank you, Dr. Fred.
Really great. And listeners, we'll catch you on the flip side. Bye for now.